Unfortunately, we're in a region that hasn't had the best statistics for heart health. We've been seeing multiple articles come out about issues with heart attacks, people having poor outcomes afterwards. We've seen things about the obesity problems, challenges with access to healthcare as well in our region, and we want to do better. In response to some of these things, the PHN Rural Clinical Council set up the Cardiovascular Working Group. It had representatives from council, from local health district, from health professionals in the area and the PHN coming together to think about different ways of approaching these problems.
We've been able to work together to develop today's activities. We had representation from Moree, we had Inverell, we've got Armidale, we've got Corindai and Tamworth, and all the facets, so all the allied health. And we've never done that before. We've never had the podiatrist in the room sitting next to the GP who's sitting next to the EP. So, and the pharmacist speaking, and how we all can do our bit, and we're all speaking the same language. So that was lovely that everybody's come on board.
We all in primary care have an important job, which is to prevent premature morbidity from cardiovascular disease. It's our job, we know what we need to do, the evidence is fairly clear, but we know that we're not achieving that in practice, and it's difficult, it's quite tricky, it's a quest, every practice is different, every patient is different. Trying to work with our patients to improve their lifestyle and their medication management, and it's really quite tricky. So we need to work together to develop new strategies and innovative ideas if we're going to achieve that difficult aim.
I came up to Tamworth to talk at the 2000 Hearts Symposium around readiness to change. So how do we identify that a practice is actually ready, or even more importantly, our team members are ready? So we look at what is it that the practice actually wants to achieve in terms of quality improvement initiative, and then how do people feel about it in terms of their role? That's going to make sure that we set due time, energy and effort to the cause. So once we identify what it is that we want to address in our practice or our wider community, then getting the people involved in the team to be committed to it.
I grew up in Walgett, which is, got a very large Aboriginal community. About 30, the Australian average is about 3 to 5%. The population identifies Aboriginal and Torres Strait Islander, but at Walgett I think the population ratio is about 33% of people identify as Aboriginal and Torres Strait Islander. And so from a very early age I sort of saw the difference in outcomes amongst me and my friends. The biggest thing, talking to a lot of Aboriginal people, has been they don't want to be treated any differently, they just want the same outcomes in terms of their heart disease, and they really don't have those. And what we really see is they have the same disease process with the same outcomes, but they're just starting 15 years earlier. So whereas a non-Indigenous person might have their first heart attack at 60 or 65, we're really looking at 40 or 45 for their first indexed heart attack. And of course then they've got the rest of their life to live with this disabling condition. And I think the biggest thing about improving Aboriginal health is involving them on this healthcare journey. So what we really need to do to improve Aboriginal cardiovascular outcomes is engage the community and bring them on board. And so we're not taking them on a journey and they're not taking us on a journey, we're going on a journey together and designing programs that make them feel safe and comfortable, and we have a good rapport with the local Indigenous community.
Well, it's wonderful to see us all coming together. They're showing all the statistics today that we are an area that does need improvement and change, and it's wonderful to see everybody from allied health to general practice to nurses to pharmacists. It's all lovely to see everybody in one spot, in one room, working together to make a difference.
We are very, very pleased to be partnering with the PHN on this really important initiative. It's through collaboration with healthcare professionals that we'll be able to improve the outcomes of the patients in this particular area.
Our role as health clinicians is really twofold. One is preventing the disease when it becomes apparent and the risk factors develop, but I suppose we've got a larger role as health professionals, as health advocates, and that's looking around making sure we design safe spaces in the community for people to exercise and be outside. We're involved in programs that try and reduce rates of smoking and try and increase people's exercise capacity, and then looking at things as a health advocacy group like maybe a sugar tax or some more primordial prevention.
It's been good to see not just having a clinical answer, but how can we get out of the consulting room to have different approaches. We've seen changes in our main street, approaches that are different in the hospital system, that are just new, and it's really good to do.
It's amazing what we can do if everyone pulls together.